Apothecary podcast. Authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories but keep it edgy yet light-hearted.
Podcasts share their career-defining drug, song and book and also share their joyful patient stories.
Welcome to the Aural Apothecary podcast. My name is Jamie Hayes. For this episode, we're joined by Dr. Ben Allen. Ben is a GP partner at Burley Health Centre in Sheffield. He's also the Clinical Director for Primary Care for South Yorkshire Integrated Care System. Ben is passionate about patient quality and experience and is interested in empowering patients to understand their health and the health system. He can often be found on Twitter exploring these topics. We will welcome Ben in a moment as he shares a drug for the Aural Apothecary formulary, his career anthem, and recommends a book for our library. Our micro discussion this week looks at Professor John Seddon's Vanguard method for service improvement, check, plan and do, and its impact within healthcare. Before all that, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both.
Evening.
Evening.
Everyone all right?
Very good.
So it's been hasn't been long since the last podcast. We sort of with a
6 days
with the pit ponies of podcasting at the moment. So we sort of cramming them in terms of holidays. So.
And the finish line is in sight. We're dipping for the tape already, aren't we?
That's it, yeah. So we're just out the tail end of the heat wave. So we're in the middle of the thunderstorm bit at the end of it. I've been to the beach a couple of times, and it's just been the news today because of the heat wave. The seas are all full of sewage. So if I run off feeling ill, then that's why. And then in work, we've been, I suppose, the medicines related bit of it is we've been talking about reinvigorating. Do you remember a campaign, Jamie? You might remember it, Your Medicines, Your Health. And it's a sort of campaign around, educating, supporting the patients in terms of taking and understanding their medicines. But interestingly, what we've been thinking about is, we've got 3,000 staff in our organisation. And so maybe we should focus inwards first and help those members of our staff understand the medicines they're taking. And so they can then pass the messages on to their community. So we're looking at a public campaign, but actually focus on staff who are members of the community as well. So I look forward to that taking off. Hopefully.
Yeah, I'm definitely on a wind down. I'm on holiday next week. So, yeah, pleasure to be back. 6-day turnaround. When football and rugby teams say in the World Cup, we haven't got a big enough squad. And so we have to play a second game within a week. Well, I'm beginning to feel what that looks like. So, still up for tonight. So, that'll be good. Just one thing I did come across this week. I can't remember where or how I got into it, but something from the Patients Association. I think it's new. I'm sure they've had something like this before. But just because we were talking about last week, patient decision aids, and it was a nice little document from the Patients Association about getting the most from your GP appointment. This whole idea of pre-planning before you come in, think about what you're going to ask, top tips, more information, that kind of stuff. And I just thought that sort of fitted with what we've been talking about recently. So, and the second thing was, have you noticed that all the podcasts that we're all avid listeners of are now taking about 2 minutes before you get to actually hear anybody on the podcast? They're so full of adverts. And of course, there's a cunning thing that they're doing here because they're now all beginning to set up their podcast plus. So you can get rid of all the 2 minutes of adverts at the beginning as long as you pay. So maybe it's something we need to think about, guys. What do you think?
They've sold out.
Unfortunately, we were all part of the campaign in the 90s to sort of disassociate ourselves with the pharmaceutical industry. So we sort of shot ourselves in the foot 20 years ago.
Okay. Look, this is normally when I give a shout out to our listeners around the globe, but with our newfound stats and data, the list is too long. So to summarise, we have work to do in South America and China, and I'll leave it at that, and you can do the rest yourself. So we are truly global.
We got one listener in Russia, if I read the stats right.
I think that's a hacker.
Hang on a minute, it could be Putin.
Another weekend of culture for me. Look, to follow up on my London weekend, I had a great weekend in Bath just to celebrate 23 years of marriage. So 2 cultural weekends back to back. Okay, let's move on. Let's welcome our guest. It's our great pleasure to welcome Ben Allen to the Aural Apothecary. Ben is a GP partner and clinical director, as I mentioned. One of his main areas of interest is helping people to reach their potential and building high-performing teams with high morale, confidence and autonomy. His clinical interests include older age medicine, reducing unnecessary medications and sharing decisions with patients. Not just thrown together. Outside of work, he lives in Sheffield, homeschools with his wife and fosters babies. Welcome to the podcast, Ben.
Thank you.
What's number one on your list at the moment that you would like to share with our our global listenership?
So I think the question you gave me was around what things am I kind of thinking about, or what? Yeah. So the question I've got in my mind at the moment is how do you improve general practice? Because general practice is really struggling in the UK, and I've now got this role across Sheffield. So my role has shifted from being in a practice to being citywide. So I've been thinking a lot about that and speaking to as many people as I can, including you at one point, Jamie, as I've been busy networking the country, trying to find the best minds I can.
Is that the best you could manage with Hayes?
He moved swiftly on.
You know he can't even peel an orange, this one. You've probably not heard that.
I wasn't after people who could peel oranges.
See, good response, Ben.
That is a good response, actually.
Well, I had people that peeled oranges for me, Ben. That was the whole point.
It was called your mother.
Half-time at a rugby match it was. Anyway, so Ben, look, I follow you on Twitter, and you're, as we mentioned in the intro, you seem to be very prolific on Twitter. I've seen, look, and it comes under the banner of improving general practice. What about your views on receptionists and reception staff, and where do you see that going? Because I know you've got some great innovative ideas in that area as well.
Yeah, so I think I took a very broad approach about 4 or 5 years ago, really looking at what are the root causes of why certain practices can be struggling, or certainly why our practice was struggling. And that came up with quite a lot of quite specific, deep cultural issues. That was quite complex. I think the bit about reception is probably in some ways a little bit more straightforward, because I guess it boils down to having a high-performing team, but just how crucial that bit of the surgery really is, I think, is a bit undervalued. They're the people who kind of take all the incoming work. Well, this is potentially how you could see it. They take the incoming work, which is all very kind of messy, and they can potentially order it and make sure that the clinical team gets the right work for them. And so things like continuity, everyone talks about continuity, and what a challenge it is when you've got all these extra staff, and if the reception team is functioning really well, continuity just happens, So there's lots of ways in which the reception team can organise incoming work, and can get extra information for the clinicians. So we don't have to. Maybe it might be there's some people we don't have to call because the receptionist did some of the work for us, and they can also communicate things back to patients if it's clinically a reasonable thing to do. So I just think the gains are enormous from having a really high quality reception. And then almost around how do you build a high performing team. I think reception has been one of the places where we've had the most gains, really.
So when I've gone into GP practices and done improvement work, there's usually a GP partner who's interested in improvement, so you talk to them, and then you talk to another one of the GPs who's usually a cynic and thinks everything's rubbish, and you sort of build up a picture of what you think the surgery's like, and then you talk to the reception team if you're clever, because they say no, it's not like that at all, it's like this, and they're the ones who are right. They've got that rounded picture of the system, and you're right, they've often been undervalued in terms of their understanding the system, but their potential to sort of triage probably isn't the right word, but to manage that demand in a much better way.
We also, where I work, Ben, I've been in general practice for 6 years, and like you, I immediately saw the benefit from a medicine's point of view in the power of the prescription clerk, and wider than that, like we now call them patient coordinators as we've moved on from the receptionist term, because of what you've just described, essentially, because they can help coordinate care, and they get a really rough deal often from the patients and the public, and so we, like you, probably try to work hard to support them as much as possible. And from a prescriptions point of view, we honed down to a smaller number of people that were more highly skilled, and we trained them better so they could do more, to take more work away from not just the GPs but also now the pharmacy teams as well. So it's right people, right jobs, isn't it? So I must just give a big shout out to Cara and Claire and Jade and others who are part of the team, and I know listen to the podcast. So yeah, they are very, very undersold.
In terms of your work on improving general practice, then, I mean, we've got a manpower issue, haven't we, or a people power issue in terms of GPs. We're moving to a multidisciplinary model, but I suppose, are you leaning towards any insights to dealing with that problem? Because I mean, it's a problem everywhere, isn't it?
I think I've kind of taken the view that the number of clinicians we've got is probably it's not enough. It's probably fairly stable overall, and it's not something I've got an enormous amount of control over. but the work itself is escalating all the time. So I was thinking, well, what is it that we can do that's within our grasp within practices, and it was very much around how do we help release the potential in the staff, and how do we improve the systems. I just think there's ways of working which just, if it harnesses everyone's potential and it's purpose driven and people enjoy coming to work and they've got autonomy and we're harnessing all the intelligence, because like with the reception, you've got people who are not medical, but they're very clever people, and they're often from the community. So there's ways of harnessing all of that, and I think you can, with the staff that we have, we can be working in a way which just enables us to do far more and higher quality work.
Now, Ben, I'm sure you're aware that there's a very good document just come out from the King's Fund. Did you have anything to do with that? So it's how to make change happen in general practice, right?
I don't have anything. I didn't knowingly have anything to do with it, but no, I really loved it, and it fits very nicely with most of the conclusions I come to, really, about how to improve general practice. And I guess part of my story as well is that I've spent the last 5 years in a practice where I'm a partner. I effectively own that organisation with a few other partners, and I'm able to make change happen. I can employ people. I can have difficult conversations with people, move people around in the team. But my role now is looking at a city where there's 80 odd practices, and I don't have any authority over those practices. So, I'm not in a position where I can make or force anything to happen. So then it becomes very much, I've got to start all over again.
Yeah, it sounds the reverse of my own experience, Ben, is I worked in a very large teaching hospital for many years and then worked in just one practice to begin with. We're now 3. But the ability to do what you've just said, nimble is the word, isn't it? And we showed that during COVID. But the ability to do things and make things happen. And so just for the listener, there are 4 things it says in this document. And it says changes work best when they're driven from the bottom up. 2, financial incentives and targets can distort priorities. 3, the soft stuff is important. And 4, people need capacity and capability to make change happen.
Can I add one then? 5, the soft stuff is really hard.
Because they're talking about culture and practices there, aren't they, and traditions and things like that. I think the one in there, there's a lot to take from this document, but it's the changes work best when they're driven from the bottom up that I think is the interesting one. And that's the sort of dilemma you find yourself in it, Ben, is you're a manager is it an integrated care system? I'm not sure what the terminology is in England. Yeah. And
Wait a minute. It said in your bio, Ben. You've probably not heard the episode. You used the word place, Sheffield Place. I'm not a fan of place, but do you want to describe what you think place means?
I took it out.
Yeah. So at least South Yorkshire, what was 4 CCGs is now 4 places within South Yorkshire ICS, and I'm in one of those places, which is Sheffield.
I was just saying it's really a fish for me. I'm not a fan of the terms, but yeah, I do realise what they are. But I'm only pulling your leg.
No, but this idea that changes work best when they're driven from the bottom up. I was involved in a project where lots of GP practices were basically given money and a bit of a free hand to do what they wanted with that money, and they came up with some fantastic ideas. They were re-engineering repeat prescribing. They were employing physios. They were engaging with the community, and they had all these fantastic ideas. Where many of them hit the buffers was when they hit the bureaucracy or the top-down management of what is the NHS or the government. And so for example, the long process that you suddenly had to go through, you just said it then, you can employ your own people. Well, if you're using NHS money, you can't employ your own people. You've got to go through the bureaucracy. If you're spending NHS money, you've got to go through procurement processes. And it was that sludge, we called it in the end, that ruined so many improvement projects. Don't know if that's something you're coming across.
Yeah, well, and I think that kind of that principle. What was it we're talking about now? The principle of change from the bottom up. That was just, so the word I would use there is just coaching. It's like if you tell someone what to do, even if they were going to do it anyway, they kind of don't want to. They want to do it less now, and they slightly resent it. Whereas if you're really like, okay, what what are the problems here and what ideas have you got, and then you support them with their ideas. They're far more likely to be the right ideas, and then they own it, and then there's far more enthusiasm, and when they succeed they feel a real great sense of self-esteem. That's totally different to like giving them 10 targets, which they may well have chosen themselves something similar, but that is psychologically very, very different. And so, yeah, that's just kind of coaching to me, really, about kind of from the bottom up.
So Ben, you've mentioned the term high-performing teams a few times.
Yeah.
Out of your 80 or so practices, how many would you consider are in the high-performing teams?
That's a tricky question.
I genuinely don't know. I've only been in this role for a couple of months, really. So I've been doing a lot of networking, and I don't even know. I mean, I don't even know how you would define something as high quality, because it's very much a spectrum, isn't it?
Yeah, so it's a bit of mischief, but I think my broader question is, and I've worked with, and I really enjoy working with general practice and primary care because I treat them as a squad, and that is the receptionist, and the new term that SDC...
Patient coordinator.
Patient coordinators, thank you. So treat them as a squad, but it is asking them the question, do you consider yourselves to be A, a team, and then B, what would high-performing team behaviours look and feel like round here? And that is the start of a great conversation in nearly all practices.
My hunch is probably quite few, because I think it's just that it's so... I think in the past you could kind of get away, the way that it's evolved, really, general practice is evolved, and the amount of workload was manageable, and it didn't need organizational development to get the job done. And we've just thrown more and more work in, and we're just working faster and faster and faster, and we're now at the point where everyone, it's just almost like it's just chaos. Like you're just churning as much activity as you can every day. You can't not see someone who's sick because you want to try and reshape the service, and that's pretty much where everyone's at now. I think is often it's just you're just trying to make sure, you're just trying to every day try and make sure that it's safe, and you can't really put that down. So I think that's why I think you're in a situation where I don't think many organizational development principles are really happening, and it's very hard to actually get them going as well.
Final one from me for this bit. Look, and it's on the demand bit, which we will come on to later as well. Look, Mark Porter on Twitter the other day, he was crying out because he was saying that his local golf club was sending the old boys and the old dears to be signed off by a GP whether they needed a buggy or not. And that policy in that golf club probably seemed absolutely perfectly fine at the chance. Well, we don't want anybody bucking the system. I tell you what, we'll get a proper clinical decision on whether they need a buggy or not. And that then comes to general practice or primary care and is then treated as work and tries to be absorbed. And it's the same with nurseries, isn't it? I remember when the kids were younger, you'd turn up to nursery and you'd be sent to your GP practice. And so there's lots of people out there just coming up with policies and procedures who have no idea of the impact that is having through the system.
It's the laws of unintended consequences, isn't it? And just to finish on this point, I suppose, if we come back to the medicines angle. So Tony Avery, who's the National Clinical Director looking at overprescribing for England, there's a very big chunk of that around the need to sort out the repeat prescription system. But as you've just described, Ben, and I'm sure you will know this, and many others who work anywhere near a general practice, is that it's almost people don't know where to start with it because it's such a beast. But I can tell you that if you do get into it big time and you train people up and you think about how to do it properly and use the right people, you can do it. But it is a hell of a job. We've worked very hard on it. Lawrence Brad, many people I work with him, and he mentioned this previously, I think, but his best analogy for the repeat prescription system in a big practice is this. Do you remember when Heathrow Terminal 5 first opened? Big trumpet, new terminal. It was down within about 2 days. What brought it down? The conveyor belt system that all the luggage moves on. And his analogy is that that's the repeat prescription system. And I think it's a beautiful analogy, and that's what we work with, and that's how we've tried to take it forward, because it can bring the whole thing down. And from an overprescribing point of view, It's just easier, isn't it, to just say yes to something, whereas you know that you probably should be saying no more often, but you just don't have time because you're on the mouse wheel. So that's going to be a big plank of the overprescribing work that's going to come in the next couple of years. So with a bit of luck, there may be some support to practices about how to help them through that. But granted, what the King's Fund is saying is, and we all know this, if you just tell people how to do something, that isn't necessarily what's going to happen.
And Jamie, I think just on that point really around asking GPs to sign letters and things. So one of the other strands of what I want to be doing in Sheffield is around communication, because I just think that people have never really been told what a GP does, and we're a family doctor. We like to be relational, and and I think historically we've just said yes to most things. Whereas now it's like, well, actually, that we've got it's life and death really, whether we say yes or no to things. Not only do we have to start saying no to some of the things that we used to do, I think that there's a real case for trying to educate the public about what really is the work that we're meant to be doing and what isn't. And I kind of almost don't blame nurseries and the public for just because they don't know. No one's ever told them what we do and don't do. And I'd love NHS England to start doing that. But in the absence of that, we're certainly going to start trying to do that in Sheffield and see if we can help the public to engage with general practice, so we can all be on the same team and we can all try and get the best out of the system that we have.
That'd be a really interesting piece of work, isn't it? You're almost sort of trying to define what general practice is, redefine what it is, and make that clear to people. I think that could be really helpful.
Yeah, I think we'll probably come back to this when we pick up the micro discussions again later on. So, yeah.
The Aural Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Thanks, Ben. So one of the pleasures of coming on the Aural Apothecary as a guest, as I'm sure you're aware, is you get to give 3 choices. And the first one, we're currently in a legal spat, so we're currently calling it something different every week. But it's basically a drug for the Aural Apothecary formulary that evokes a powerful memory for you. This week I'm going to call it Archipelago Drug, because that was suggested by somebody. But anyway, the sentiment is the same. So what would you like to offer us?
I was a bit torn, really. I've got a few options. So I toyed with bisphosphonates and statins, and I went with diclofenac in the end. So I'll explain the link. And it's very much around shared decision making, and often around, well, with bisphosphonates and statins, it's about numbers needed to treat and degrees of benefit. And often I think the degrees of benefit are underestimated or overestimated, and how you're meant to implement and follow a guideline with shared decision making when you don't know the numbers needed to treat is beyond me. But diclofenac is even a bit more interesting because it fell out of favour, didn't it? Like it must have been about 10 years ago. When they found that it really increased risks of cardiovascular events. And I think for some people it's just like you never prescribe it anymore. Although when I looked at the data, it looked pretty similar to ibuprofen, although the ibuprofen, the confidence intervals were massive, much less so with diclofenac. But it's that case of where does shared decision making come into this? So if you've got somebody who's got, let's say, rheumatoid arthritis in their 70s or 80s, they're really debilitated by pain. Diclofenac's the only thing that will help them. And some people will just never prescribe it because of this slight increased risk of heart attacks and strokes. And in my mind, that's a shared decision. Do you want to have less pain with a slight higher risk of heart attack or stroke or not? So I love shared decision making, really. And I guess that diclofenac's probably on the cusp of what some people would just say, no, you just don't ever prescribe that to a 70-year-old because it's too risky. And I don't think there's any kind of guideline that says we can or we can't. But that's just an interesting one for me.
All I can think of when I think of diclofenac, and they are listeners to this podcast, Jonathan Underhill obviously is a good friend and listener and helps us out with lots of things. And he will relate to this story, but it's a story concerning diclofenac and Canoe Man. You know Canoe Man, who's just been on the TV in the documentary, the guy that went out to sea and got lost at sea?
Oh, is this the guy in Anglesey?
No, it was over in the North Sea, wasn't it? He faked his own death and then lived in the attic next door for 5 years or whatever. Canoe Man. And so the day that diclofenac was going to appear on the front pages as a bad non-steroidal, and it was about to happen, and Professor Neil Maskery put an awful lot of work into this, Canoe Man happened, and it wiped him off the front pages of the papers. And so diclofenac never came round again for years.
I was going to say, I wasn't going to bring up Canoe Man, but diclofenac's an interesting one because it's one of those drugs where the paradigm really does shift, doesn't it? Because there was a time when diclofenac was the sort of the flavour of the month, I suppose. And I suppose maybe that's why it's in your mind, Ben. I don't know. Is that at one point, I'm not saying we never understood the risks, but we never really talked about the cardiovascular risks 15 years ago, did we? And I always see it as one of those drugs that it's still weird to me that it's one of those drugs that's on the sort of on the dangerous list, if you like. Just because when I was more involved in practice, it was one of the ones we talked about a lot over the other drugs, including naproxen.
Hey, Ben, as the other clinician on the podcast tonight, I agree with you wholeheartedly. These guys are way out of practice now, but what you're describing there is common, isn't it? So we talk about unlearning. So people learn something, it gets forced down their throat. People then think it's dangerous, in inverted commas, and you're dead right. If you don't have a cardiovascular risk, then you can plow on. You can talk about the risks and the benefits, but yeah, some people will get better pain relief than they will with naproxen, and you'll have less cardiovascular risk. But if you don't have a cardiovascular risk and you've discussed it with the patient and they're happy, then absolutely jog on. And so, yeah, it's guidelines, not tramlines, isn't it? So going back to Jonathan Underhill again, a nice guidance. And so we've got to get people to listen, in the polypharmacy multimorbidity world, people are going to have to go back to thinking for themselves and relying less on a single organ guidance, because that's what we have in front of us. And so your case of diclofenac, although relatively simple, is a really good example of how we're going. And when we had Louise Newson on talking about HRT, she would give exactly the same story about if I discuss the risks, if they've got a breast cancer in the family or cardiovascular risk, and we've discussed it and they decide that they want to go forward and we've documented it, medico-legal, then that's okay. So yeah, great choice. I'm with you as a clinician.
Thank you.
Okay. The second thing you get to give us is a career anthem for the Aural Apothecary Spotify playlist. So what would you like to give us?
So I've gone for This Is Me by The Greatest Showman. And I think there's a few angles to this. One is about me, but also the other is about the people in the team. So I guess I've had the privilege of being at a practice where I've been allowed to be myself. I've been allowed to take a leadership role, even when I was the most junior partner by probably a decade or more. I just started being myself. I saw the need that was there, and I just started leading in the way that felt like the right way to lead. And I started reading, and I started being able to implement the things I was reading, and I really was just being myself. I guess partly it was the authority that had been, that was inherent in the role that almost enabled me to be able to just think, well, screw it, I'm just going to be myself here, because actually there's no one who can tell me not to be. It's so releasing and so freeing, isn't it, to be able to just to be yourself in a role. You bring everything that you can to that role, and you start to be less inhibited. But that's what I want for the rest of my team. I want them to be able to say, this is me, and for them to be able to have exactly the same experience of being in a fearless organization where they can be themselves, where they can see opportunities, they can respond to need. They're working to principles, not rules. So when things screw up, the way that you approach that in a way which is empowering and encouraging, but also where you can learn. And so yeah, and in terms of the gains you get from an organization, when people say the NHS is in crisis, I don't think anyone's kind of saying, we need to make sure that everyone can be themselves. But when everyone is being themselves, the gains are enormous. And how much more do you enjoy your work as well?
Great choice.
Burley and Sheffield are lucky to have you, Ben.
Yeah, indeed.
And I've got visions of you breaking out into song now in the GP back, because it's maybe that's what we need is GP the musical.
We actually did a bit of a hash up of a music video. Someone wanted us to do something and we did it, so I could maybe forward you that. But there's been talk about doing some Christmas version. But yeah, they had me singing a few of the lines onto my dictaphone.
Oh, get that
on my computer.
Twitter gold, that is. Give us that.
Yeah, that's not on Twitter.
Yeah, some things need to stay off Twitter. Excellent choice. Okay, and the third thing is a book for the Aural Apothecary Library. So what would you like to offer the listener?
Yes, so I'm gonna do a little rundown of the near misses, just because I just want to get them in really. So Jim Collins, so good to great and built to last were kind of two studies that were done in America, I think, on organisations, and just there's loads of great principles in there. Quite old books, but really great principles. Nancy Klein, Time to Think. Brené Brown's just fantastic. Simon Sinek as well. But favourite author overall, Patrick Lencioni. His books are brilliant. You know, he's entertaining on YouTube, and lots of his books start with the story, a narrative. It's so easy to read, and then the principles at the end. But the book I'm going to go with is The Advantage, just because that one's not got a novel aspect to it, but it's just like everything that he. You know, it seems like he's just put all the principles in one book, and he says these are really simple. Like, these are not complicated principles. It's just that barely anyone's actually doing it, and so and so he's probably the person who's inspired me the most in terms of what to do and how to do it.
Oh, I've not heard of him, James. Have you read his books, James?
Read them all. They're stunning, and they're very easy to read as well, as Ben said. So they're fables, aren't they? They're leadership fables, and the way that he writes is the way I'd like to be able to write a book like that.
You may have come across the 5 dysfunctions of a team. So that's one of his models.
Yeah, so that's the very popular one that gets spun out as workshops. But there's about 8 or 9 of them, isn't there? I think I can point to them.
Hang
on my
on,
bookshelf.
there's a theme here. Do you remember last week Dave Murdoch picked a book that was a theme of nurses' manuals? Do you remember that? So we're moving into a new field here. Excellent. Okay. So The Advantage by Patrick Lencioni. Where's he from?
He's from California. He's honestly, once you start reading them, you'll go through, because again they're easy to read, aren't they, Ben? But they are such profound lessons. So
what are they? Is it about health, or is it about teamwork in general?
Yeah, it's about teamwork. I don't think he's got any. So I'm looking at now. He's got one's about the ideal team player. One's about the truth about employee engagement.
Death by meeting.
Death by meetings. Yeah, that's very good. Yeah, it's nothing to do with health at all. It's all about how to have a healthy organisation, basically.
And yet it's all to do with health.
There you go. Absolutely.
I'm excited to read one of them.
Oh! You're in for a treat. You're in for a treat.
Yeah, I'm going to put that on my list to read.
Yeah, you can get them on YouTube, and you can often get a bit of a feel for some of these books.
Excellent. Okay,
our micro discussion next. Me this week, I think. So again, continuing the theme, look, a paper from Musharat Ahmed Landaru. I think I've done that okay. In the British Journal of Healthcare Management, published last month, and for those of you on catch-up, that's July 2022. It's a literature review looking for peer-reviewed publications that use the John Seddon's Vanguard methodology. Systems thinking, check, plan, do. That's the Vanguard. We'll go into it in a bit more detail in a moment. But it's a literature review, and they were just wondering how much published evidence is out there. And this is where Gimmo and I bow our heads in shame.
Yeah.
Because the literature review only found 6 identified publications, and that was made up of 3 book chapters, 2 journal articles, and 1 consultancy report. And so Gimmo and I bow our heads in shame because we did a brilliant piece of work on this many years ago, and it never got written up properly, did it, Gimmo? We did write it up as a consultancy report, but it certainly was never published.
Not the same.
Thank you. Certainly never published. So who wants to start me off with a discussion on the Vanguard methodology?
Yeah, I mean, I guess so on the one hand, it reads like a lot of papers about quality improvement and service improvement methods. It's a poorly evaluated area for lots of reasons. And if you're interested in this sort of stuff, Mary Dixon Woods in the This Institute does a lot of work at looking at the evidence around quality improvement and service improvement, and a lot of them read very similar to this in that, you know, the evidence that's out there is book chapters, is rhetoric, is case studies. But what evidence is there is pretty good, I think, or it makes a pretty good case for this method. And one of the things that I think we liked about the Vanguard method, Jamie, was that it takes sort of elements of lean, it takes elements of QI along with sort of behavioural change, and really just talks about taking the waste that doesn't add value to patient care out of a system. And so the examples they describe is where they've done that. And so I think the three sort of themes he talks about is getting the work processes right first time so that financial resources are used optimally. Well, Ben, that's what you were talking about earlier, wasn't it? About making more out of the system. And that's what we saw, didn't we, Jamie? Making sure that service users' needs are met correctly the first time. Well, that's why we're talking about remodeling what receptionists do and reducing unnecessary lengthy or complicated processes. So I thought it made a good case for it. You couldn't call this a gold standard of evidence for it either.
Some way off, but I think we all feel that it is the right way of thinking about things. But as you say, if you look at it in an academic sense, you'd say that it hasn't got a wealth of data associated with it. But Jamie, maybe you should just remind the listener.
Sorry, in healthcare, that's the point here as well. So this
healthcare
was looking in health and social, healthcare and community care, I think, isn't it? But in other areas, housing, call centres, there's a raft of published evidence from the method as well.
But we should remind listeners that your book for the Aural Apothecary Library is
Freedom from Command and Control
by John
Seddon, yeah.
John Seddon.
And so let me just share with the listener, look, the work that Gimmo and I did. I've made some notes. I couldn't find the report, but look.
We could have Googled it.
Talking about change from the bottom up and falling into that advice trap, really. That's, we can fix you. So that was one of the lessons we learned very quickly on this project. But the aim was to learn how to study general practice. So I loved that. How long ago was this, Gimmo?
Cool, 7 years ago.
Yeah, the aim was to learn how to study general practice. So we brought with us locum GPs to free up a couple of the senior GPs who worked on the work with us. We took over the training room for 6 days. We had full access, which was a really impressive commitment from the practice leadership team. 4 skilled facilitators, so 2 from Vanguard, and then me and Gimmo, so maybe 2 and 2. We sat on the front desk and met patients as they turned up. We listened into the phones as the demand came in, and we could hear the anxiety in their voices. We could hear and see the failure demand all around, created by poor communication, safety netting sometimes not going quite right, as we discussed last time, letters and websites. We interviewed the patients as they had been treated by the GPs, so we interviewed them on the way out and asked a number of questions of them about their visit. Was your problem fixed first time, etc., etc. We asked for data. The data was really interesting because they said, we can get that data, but it was obvious that they weren't using that data on a daily or a weekly basis. We brought with us a local cardiologist. So a consultant cardiologist came to the practice and did a joint clinic with one of the practice GPs and saw the patients who were at the top of the waiting list in that practice for cardiology. And that debrief session was quite special. The consultant was bowled over by the level of complexity that she saw in primary care. So this was a secondary care consultant, had not stepped foot in primary care for an awful long time, if ever. And she was absolutely bowled over by how skillful the GPs were in dealing with the consultation and dealing with all that was going on, the chaos of people's lives. Obviously, when she was seeing people in outpatients, and we'll let Steve have his piece in a moment on the cardiologist, but they were really impressed with the detail and knowledge and the skills of the GP, made her realise that she should have much more confidence in their referrals. So it was one of those things where the CPD sessions we used to have, where the local GPs would meet with the local consultants, and those things have fallen away now. So that's a big gap in the system. But I've described it as probably one of the best initiatives that I've been involved in, and sadly, we never published.
So, Ben, do you want to come in at this point?
I happen to be kind of halfway through that book. It might well have been Jamie who recommended it, and I'm guessing I'm going to be gleaning more from the book than the actual paper, because the paper was a little bit scant on actual. It was mostly a lot of jargon that unless you knew what it was, you didn't know what they were talking about. But I was really impressed by the principle about rather than about economies of scale, economies of flow, and I'm yet to fully grasp what that means, but my understanding of it really is just around how do you make things work well, and economies of scale often doesn't make things work well. If you were to have a GP practice merge and be 4 times as big, you'd have one big reception team. You would not have economies of flow, because at the moment those receptionists are all working very intimately together. They're a team of about 8. Now, you wouldn't want to have a massive team. It's very relational, and they know the patients. They even recognise the number when it's flashing up. I mean, that degree of understanding and knowing the patients is phenomenally good for flow. So that was interesting. The failure demand again was also very interesting. I think that we just kind of we just measure activity like number of appointments or the number of phone calls. Well, how many of those were pointless or just reworking?
Created by something else. Exactly.
Yeah.
Right. Yeah.
And so that level of reflection isn't happening. I hadn't even thought of it, I don't think, until I read the book. And that thing around, having the decisions being, the autonomy really of the people who are close to the work, being able to have the autonomy and the agency to be able to change the manner in which they work. You can really see the potential benefits there.
Yeah. I'll tell you something else. There was a document that came out a couple of months ago now, and it was a little bit right-wing think tank called From the Policy Exchange. It was called At Your Service. And it was a proposal to reform GP and enable digital healthcare at scale. Now, Ben, you might remember this, and there was a lot written about it. And I took the time to have a look at it, okay, because it had 23 recommendations. And I'm not saying that I'm siding with everything that they're saying, but recommendation 16 says primary care should monitor and set out proposals to reduce failure demand. And so wherever we look, wherever we think, whether or not there isn't a huge amount of research about this sudden workflow in healthcare, I'm absolutely sure, and I think we all are on the call, that failure demand is a massive issue, and it's all that unintended consequences. And until you map it out, and that's why people don't want to take on repeat prescription systems, because you've got to map the whole thing out in relation to all the unintended consequences if you do X versus Y. And that, I think, is just in the very difficult tin. I really do.
Yeah, so not treating all demand as work. So there's the value demand and the failure demand. And then if, within these squads in primary care that we talk about the jobs that people have, there'll be some people, if you look at their job, it will be dealing with failure demand. And that's not a rewarding thing to be doing either. It's not fulfilling. And so that, that purpose, autonomy, mastery that they talk about. And so with the consultants that were helping us out on this project, I learned so much from them on their style of delivery, facilitation, avoiding the advice trap, avoiding the, we can fix you now, we know, they really let it come out over 6 days, didn't they, Gimo, of letting the practice discover for themselves those moments of discovery, and they were really powerful. They were really powerful moments. The final bit from me, we often get caught up with the efficiency drive. And one of the terms I took away from John said, and I've seen him speak a number of times, is that in healthcare in particular, we can become very efficient things, but we can do the wrong things righter really well. And so that's that efficiency effectiveness thing, isn't it? We can get really good at some things, but they're just not the right things to be doing in the first place. And sometimes we can give those roles to people. Can you do this for us? And they can get really good at it. But in an ideal system, that role wouldn't exist.
The phrase Alan Wilson used to use was, we're scraping burnt toast.
Okay, a big thank you to Ben for joining us on the Aural Apothecary and for sharing his stories, his marooned medicine for the formulary, his career anthem, and his book for the Aural Apothecary Library. Coming up next time, we'll be joined by Professor Thompson. Claire is a multi-award winning scientist, entrepreneur, non-executive director and philanthropist with more than 20 years experience in the pharmaceutical industry. Cool, that's a lot. We look forward to welcoming Claire next time on the Aural Apothecary. You can contact us via Twitter at Aural Apothecary. We're on LinkedIn, and you can email us at auralapothecarypod@gmail.com. Over to Gimo for the final ingredient.
Okay, so thanks, Ben. I enjoyed that, and it was nice to reminisce about an old piece of work, Jamie, as well. So does anyone watch Lorraine on Wednesday morning? I know you wouldn't have, Steve, being a practicing clinician, but if you did, you would have seen another GP, Dr. Hilary Jones, I think it's a GP, Dr. Hilary Jones, issue a warning about something called thunder fever. So what is thunder fever? Well, according to the Metro, it's a potentially deadly combination of high pollen counts and wet weather that can trigger potentially deadly reactions in those suffering from hay fever or asthma. So it's been blamed for potentially thousands of allergy attacks and deaths. And it's a combination of events, such as pollen being sucked up into moisture-rich clouds, that sees that pollen smashed up. And so formally it's too large to enter human airways, but it shatters into smaller particles that can. So allergy expert Dr. Sophie Farouk of Imperial College NHS Trust warned on her Twitter account that storms currently battering Britain could result in thunder fever on a scale not seen since 1994. And what happened in 1994 is a study showed that thunderstorm-linked asthma epidemic resulted in about 7,000 people suffering attacks in the space of 24 hours. So the advice from Dr. Farouk, if you do have hay fever asthma, is stay indoors, close windows, stock up on antihistamines, and keep your reliever inhalers close by. I have not looked at the evidence underpinning that, but there you have it, a serious message from today's final ingredient, particularly if you're asthmatic. Take care in the storms and make sure you stay tuned to daytime TV.
This was a 3 Apothecaries production. Sound engineer Jimbo Slough. Original music Jamie Brewster. Artwork by David Baker.
Thanks for listening to the Aural Apothecary podcast. Do not listen more than 8 times in 24 hours.
This episode of the Aural Apothecary is sponsored by OneLessPill.com, a medicines optimization consultancy.